medicine. And guys, come on, thanks. um, Dr. Quezada also completed her postgraduate residency training in internal medicine and fellowship training in gastroenterology and hepatology. She is passionate about equity, inclusion, and diversity, and brings the lens to her work in academic medicine. She is Associate Dean for Medical School Admissions and Associate Dean for Faculty Diversity and Inclusion at the School of Medicine, and has worked locally, regionally, and nationally to amplify physician workforce diversity and to impact the climate in which future and current physicians train and practice. Dr. Quezada is a practicing gastroenterologist who subspecializes in inflammatory bowel disease and is recent past chair of the Diversity Committee and current co-chair of the Equity Task Force for the American Gastroenterological Association. She is also a member of the Diversity and Inclusion Task Force for the Crohn's and Colitis Foundation's National Scientific Advisory Committee. With that, we're going to have her come up and present on how to integrate into our curriculum. Thank you.
Okay. I hope it's okay if I take my mask off to speak. Okay. All right. Well, good morning, everyone. Thank you so much for having me. It's great to be here. I always love, getting a chance to have some interprofessional, collegial, professional conversation. And hopefully this talk will generate some meaningful conversation. I'm really excited to talk about incorporating DEI into our curricula. This is work that we've been doing at the School of Medicine for about 5 years now. And it's, evolved interestingly over time. And if there's one lesson we've learned is that that work is never done. You really are continuously having to evaluate and work on making sure that you're incorporating DEI in the curriculum. And actually, I think an equally appropriate title for this talk would be mitigating bias in the curriculum, because when you're doing that work of trying to make sure you're thinking about diversity, you're thinking about equity, you're being inclusive in your curriculum, oftentimes what that means is that you are constantly coming up against bias that is just embedded through and through in our curriculum. When you look for it, you will find it. And so much of what I talk about is going to be about the bias that we encounter and how we can try to dismantle that. And of course, most of the bias that we see when we encounter it in our curricula is there because of implicit bias, which I'm sure is now like a household term these days. When I first started presenting about this years ago, we'd spend like an hour defining what that means. I think everybody now knows, we use this interchangeably with unconscious bias. These are quick associations and connections that our brain is designed to create, and all of us as humans have this capacity. And it does, without our intention and unfortunately without our control, influence our decisions and our behavior. Of course, there are also conscious biases and conscious preferences. Most of our connections, though, are often unconscious. And it's always important to recognize that we all have it. If we're humans, we have it, we have bias. We may not all have the same biases, though. And this is why it's important to have diverse teams, diverse educators, diverse classrooms, because we are going to learn from each other, from our different perspectives, be able to fill in those different blind spots that we might bring into the conversation. But if we're going to mitigate that bias, then in addition to knowing that it exists and what it is, we have to acknowledge that we have it and then be able to recognize it, be able to see it and identify it so we can do something about it. It's always easier to see it and recognize it in other people, much harder to recognize it in ourselves. It's much more challenging. Of course, it's not only existing at the individual level, it's built into systems, and that's because people brought their bias and built it into those systems, but it can also be very much more, I think, sometimes insidious and hard to recognize it at the systemic level. And then even for those of us who are educators and have presentations, it can be and manifest in our presentations, whether we created it anew ourselves, or in some cases we inherit lectures. For example, I inherited 2 lectures actually, and I'll share some examples coming down the pike. So As we were looking through in the medical school, and I think our curricula are very comparable, and there's going to be a lot of parallels between both of our curricula, we recognize there are a lot of different phases throughout the curriculum where bias can seep in. So we tend to think about our curriculum as sort of the pre-clerkship or preclinical sort of phase, which is mostly classroom didactics, like this being in the lecture hall, there are presentations. Sometimes there are what we call clinical correlations, where patients are educators and they will share what their disease presentation is like and answer questions from the students. We also do some small group and case-based sort of discussions, team-based learning, and then other forms of patient interactions. And of course, that we call practice of medicine, where students actually do, even in their first and second year, have the opportunity to go into clinical settings and learn to take patient histories and physical exams. Really, in all of these different settings, there's opportunity for bias to seep in. And then certainly in the clerkship phase, now where students are fully immersed in the clinical setting and on rotations, bias can present on rounds, during procedures. And then what is common in both the classroom and clinical setting is thinking about noticing patterns. Who's comfortable speaking up? Who tends to be the one who participates more actively versus those who don't? Also, who's called on more often and invited to participate versus who is not invited as often? Our own assessments, again, as educators, our exams can be biased. The way our questions are phrased can sometimes perpetuate biases. And then also how we evaluate and give feedback to our trainees can also be another setting in which bias can present. So I was asked to talk about incorporating DEI into the curriculum. And I often think it's important to remember that DEI is not one big same thing. It's diversity, equity, inclusion, which are three different things. And in the case of the curriculum, I think it's helpful to kind of tease apart what that means, or at least for me, it was, what does it mean to me to incorporate diversity into the curriculum versus equity versus inclusion? So diversity usually to me means who's represented, who is there. And for example, as in my role in admissions, I think about diversity of the class, that when I bring in a group of students, am I bringing in a diverse class? In the curriculum, we think about oftentimes the diversity of the patients that we are presenting to our students. This might be a good time to share that part of the process, and I mentioned we've been working on this in School of Medicine for a few years, part of that process has involved developing a committee, very uncreatively called the Educational Content Review Committee, that reviews educational content. And there are different phases to that. The first phase being, let's say I'm going to give a lecture. I'm giving a lecture on celiac disease, let's say. So I have my slides, I present it to my course director, who will be the first phase of the review. And we'll just look through the content and make sure that it's up to date, that there aren't any any errors or anything that needs to be challenged or any missing information that should be included. Then it goes to the educational team, and they review it more for formatting. Is it accessible visually? The colors, the font. Is it too busy a slide and you're trying to pack way too much, or you're using a lot of acronyms that you haven't defined for the student? So again, thinking about accessibility is a big part of what the general education team looks at. And then it comes to the DEI phase, or the DEI committee for review. And again, we're looking for bias. Do we see patterns and evidence of bias in the curriculum? And when we find it or identify it, we give feedback to the lecturer on, hey, here's a way that this could be presented better, or here's we try to offer some solutions, not only just recognize that's not a good slide, but also here's how you could make it better, or here's a resource that we think would be helpful to you as you're looking through that. So time and time again, as we started this process, by far and away, the most common feedback we had to give over and over and over again: please include diverse patients in your slides. We live in a very diverse work in a diverse city, a diverse state. Over and over again, there were slides. Does anyone have water? I'm sorry. There were presentations where all the patients were white, all of them. Like, this is not the patient population that our students or we are taking care of. So we are not accurately representing the patients that ultimately our trainees are going to be responsible for taking care of. Also, the common theme was oftentimes all the patients were men. And the only time women were included was if it was about something that had to do with pregnancy or something that had to do with mental health. Yeah. So we are baby makers and we're crazy is basically the message that I would take away from that. So thinking again about just multiple dimensions of diversity, including race, ethnicity, gender, but also sexual orientation, ability status, religion, et cetera, just really thinking broadly about diversity. Are we appropriately representing a diverse patient populations for our students? And then also about the disease processes and thinking about how much time are we dedicating in the curriculum on some disease processes versus others. And one of the patterns we would notice is a lot of the time, there was a lot of time where time is precious, right? There is never enough time to really go in depth and detail to talk about any particular topic. And yet we would find that there was too much time often saved for teaching about disease processes that predominantly affect white patients. And those disease processes that affect people of color would have shorter amounts of time. And so those were some patterns also that we noticed. So I think about that with diversity. With equity, I think about incorporating discussion around health equity and health inequities. So what are some of the disparities that we see across disease outcomes? And it's not enough just to acknowledge that the disparity exists, to unpack that and go a layer deeper and talk about what are the underlying reasons that those disparities exist. And also to acknowledge that race-based medicine unfortunately exists. And how can we unpack that? Where does it exist? And how do we undo race-based medicine? And thank you so much. And then inclusion. I was just hesitating because I wonder if I can get rid of this little thing or like move it. There we go. Yay. Inclusion just in terms of, again, participation, who is being included in the learning process and in the discussion. Are we including diverse educators, diverse styles of education, and then also being inclusive in terms of the voices that we incorporate into our feedback and how we evolve the curriculum moving forward. So I'm going to go dive even more deeply, give you some actual examples. In terms of diversity, for example, again, who is represented? You can imagine that just not including certain patient populations in your talk already is unfortunate because you're basically erasing the fact that those communities exist. But in many ways, it also is actually a failure to appropriately teach pathology and how it could present differently in different communities. And a great example of that was in dermatology, where clearly different dermatologic pathology looks different on different skin tones. And therefore, we were failing our students by having a presentation of dermatology on all white skin. We were not showing what these same disease presentations could look like on different skin tones. And therefore, our students and trainees were not prepared to recognize that in the patients that they will see who are not white. Contact dermatitis is one example, but obviously there are multiple examples. There was actually a dermatology lecture that I reviewed that had 66 images of patients. 61 of them were white patients. And the only 5 Black patients that were included in these slides were examples of syphilis, HIV, Stevens-Johnson's, and vitiligo. And these were the areas where the vitiligo was being shown. So not only, again, thinking about being diverse in terms of who you're representing, but also even thinking about what are those sort of weird underlying messages sometimes that we communicate when we include diverse patients. There was a trauma lecture that I reviewed, and time and again, the pattern in this lecture was that white patients were being included in cases where the trauma was a result of an accident, like a car accident or somebody fell off a ladder. And then Black patients were being included in very violent scenarios. gunshot wounds, knife stabbing. And again, what is the underlying theme that we are reinforcing and communicating in those lectures and slides? And then our students were the ones who gave us the good feedback in noticing a pattern that the patients that were invited to be teachers in those clinical correlations were frequently white patients and affluent patients. So thinking again about the diversity of the patients in all the different ways our patients are presenting and are presented to our students. And then it's not only about the patients, even about their providers, that when we are showing an image of a pharmacist or a physician that's taking care of a patient, time and again, I kept seeing men, mostly men, usually white men, and just encouraging our lecturers. How about putting a woman of color in there as a physician? That would be great. So just again, encouraging people to think broadly. And a lot of the time, again, these were not new lectures that people created de novo. They had inherited these lectures. These have been passed down year after year, decade after decade in many cases, and not really being intentionally updated and refreshed with this in mind. And that's, again, why I feel like, again, because of those implicit biases that we have, that we just sort of just take that for granted and just sort of like, well, yeah, this is the lecture that my former professor gave, and it was a great lecture, and then it's great. And then just not really critically looking at it and thinking about it in that way. I mentioned about thinking about, again, being intentional, including disease processes that affect diverse communities, and also including and increasing the use of singular they and including non-binary cases. So thinking just more intentionally even about gender and how we include that in our cases. Oftentimes when gender is included, we noticed a pattern that it reinforced very dated gender roles in society. And also, again, just recognizing opportunities to leave gender out of the discussion or leave it in as a non-binary gender. And in fact, we really have moved toward a place now where we think very intentionally about if we're going to include race, ethnicity, or gender in a case discussion, why? Why are we including it? What is the purpose that it serves? Does it help us teach this case an important part about this case, or does it actually not really matter in this particular case? And if it doesn't, then just leave it out, because sometimes what we tend to do, our implicit biases make us reinforce these biases and sometimes stereotypes even. So an example would be, for example, previously, a classic one-liner that we would start with the 65-year-old African-American man with a history of liver disease and Lyme disease who presents with hematemesis. I'm a gastroenterologist, so I like GI cases. And so I would think through as a reviewer, for example, and I would say, okay, this is a hematemesis case. Does the fact that this patient is African-American have meaning here? Does it matter? Does it in some way impact the outcome? Does it impact the underlying etiology or mechanism? So really being thoughtful about that. In this case, I would say, no, it doesn't. This could have been a white patient presenting with hematemesis. It could have been, basically any race or ethnicity. History of liver disease, heck yes, that matters if they're presenting with hematemesis. If you fail to tell me that this patient with liver disease or the patient with hematemesis has liver disease and you're calling me at 3 in the morning, I'm really gonna wish you'd told me about that. Meanwhile, Lyme disease, not really relevant, not pertinent, doesn't really need to be there. So again, the newer sort of refreshed presentation would be, oh, and age. What about even the age? Age, yes, I would say age matters because we know that prevalence of malignancy can change, increase with age. So does osteoarthritis and the likelihood that maybe this patient might be on NSAIDs, right? So age, yes, it does change and the risk stratification that I'm gonna think about for this patient. So 65-year-old with a history of liver disease presenting with hematemesis. That's really what I need to know. And when I'm teaching my students, I think about that too, because again, I don't want to reinforce assumptions that might be actually inaccurate or incorrect. And just as a side note, I still remember our celiac disease lecture that I had when I was a student here literally 20 years ago. And they kept showing women in the pictures. There's just a lot of women shown in that particular lecture. So I took with me the assumption and association that celiac is more often seen in women. I just sort of absorbed and interpreted it that way. I just sort of took that for granted. Then later as a presenter, when now it was my turn to teach, I explored that. I was like, nope, there's no gender prevalence with celiac. All genders are equally capable of having celiac. So I had to undo that. So again, when we put it in, just being conscientious about how certain patterns might actually create assumptions and connections, associations that we fill in the blank with as a learner that may not actually be true or accurate. So we can talk about equity now, health equity and health inequity. Again, just so important. And I think we're doing a better job, but it still is not, it's still an evolution and work in progress to make sure that we are actually including the discussion, the fact that disparities exist, and teaching about these in our instruction. I over and over again, not as frequently as the need to have more diverse patients presented, but one of the other frequent type of feedback that I have to give oftentimes is to encourage our lecturers to include the fact that yes, there are health disparities in this particular disease process, and that should be taught. Our students should know that that exists. So for example, and it's funny because, I'm a gastroenterologist, and I already told you I was reviewing a dermatology lecture, and then I might be reviewing a neurology lecture. I'm pretty good at knowing about disparities in inflammatory bowel disease and other GI disease processes. I don't know all the disparities in all the diseases that exist, but I look it up every time, and it takes me about 1 minute, and I usually find them. It's not hard to do. And I was reviewing a neurology lecture, it was about stroke, and I'm like, well, let's see. What are the disparities out there around stroke and stroke outcomes? And oh yes, a whole slew of very high quality literature showing that yes, there are disparities. And so the feedback was, hey, this is the perfect opportunity to teach our students about health disparities in stroke outcomes for patients. And then again, to not miss that opportunity that as you're sharing those differences, to explain why they're there. Because when we don't explain them, then again, we've left a gap that will be filled in inevitably. And oftentimes it could be filled in with inaccurate information because we're human beings that are bringing in that social narrative that we all have been raised with oftentimes. One of those narratives that we've worked very hard in the last couple of years to try to undo is race as a biological construct, right? And recognizing race as a social construct, that race is not biologically or genetically defined. When you talk about diseases presenting differently or having different outcomes across races or ethnicities, but you don't explain these social reasons that are driving those differences, and oftentimes people fill in the gap and think there's some underlying genetic reason, biological reason why those differences exist. And so it is our job to intentionally nip that in the bud early and explain really what the social determinants of health are that are perpetuating those disparate outcomes. And acknowledging, and I mentioned earlier, just unpacking race-based medicine. If you haven't already seen or read the New England Journal article, it's hidden in plain sight. The author's last name is Vyas, V-Y-A-S. It was published in 2020. It's an excellent, actually relatively quick read, actually, but she actually lists at least 13, if not maybe 15 different examples of equations and formulas that are embedded throughout medicine that are race-based. And certainly the GFR was one of these included in that list. And at the University of Maryland School of Medicine, we decided to tackle GFR first because of how far-reaching its impact really was. Some of the formulas that were included in that article I just mentioned to you, I would say a pediatric one, and I would talk to my pediatrician colleagues, and they're like, we never use that. There's another one for colorectal cancer, and I'm a gastroenterologist, like I had never even heard of that formula. I've never used it. Fortunately, hopefully most people aren't using this weird formula. But GFR we use every day, all day, for many patients. We use it multiple times a day for almost all of our patients, anyone who's getting a basic metabolic panel. And since I was a medical student, and well beyond that, I still remember you would get the result reported as African-American GFR and the non-African-American GFR. And it was never explained why that was the case. It also wasn't questioned why that was the case. But the gap was filled with there must be some biologic reason why this is done this way. Then when we did the work of actually unraveling that and digging deep and figuring out why this was the case and learning that it was really rooted in white supremacist theory, that people fit in neatly into these racial categories that are biologically and genetically defined, and that there are certain physical characteristics that can be well described in one race, but not in the other race. Anyway, it was a big mess. It was terrible. And obviously negatively impacting a huge community, and all of us really ultimately, which was why we really took that on as a system to stop using that particular equation. The good news is at the University of Maryland medical system level, we have our chief health equity officer and also chief diversity inclusion officer working to, and I'm actually on the health equity work group, now looking at multiple those other formulas and those other places where it's still there and what we can do to dismantle that. And then just thinking about pharmaceuticals, right? And thinking about medications and how some are marketed particularly by race. And Vital is a great example of that. The combination of isosorbide dinitrate and hydralazine, which initially in a multiracial study did not show improvement, but then later when Nitromed was the original pharmaceutical company that was sponsoring these studies, decided, well, okay, let's just look at it in a study where only African-American patients are included, and they were able to show that there was some benefit. And then it became marketed as, this is specifically for Black patients or African-American patients. This is a better drug for you than this other drug. And that really wasn't the way it was studied. It was not shown or proven to be more effective in the Black community compared to other communities or compared to other drugs. But it was, and continues actually, because this was just a few days ago, I found it continues to be marketed to Black patients. That original company, Nitromed, did go out of business and is no longer the pharmaceutical company that sponsors this drug. But the other thing is that always just drives me nuts is just price. And of course, Vital will be $384 for 90 tablets, but you can get isosorbide dinitrate and hydralazine separately, the same amount, and it's much, much more cheap. So let's get back to disparities and lectures. Again, talking about equity in our lectures and how we teach. I think one thing that is important to think about is also just striking that balance where we are being inclusive, we are presenting diverse patients, but we also don't want to do it in a way that is perpetuating stereotypes, right? That we aren't always and or only including diverse patients in certain scenarios that tend to, again, reinforce some of these biases that some of us may bring to the table. So for example, always and or only including Asian patients because we're talking about hepatitis B. Or only including a patient in the LGBTQ+ community because we're talking about HIV or some, sexually transmitted disease. Change it up. White people get HPV, straight people get HIV, just to kind of remember that if, again, you're going to include social identities in your cases to be diverse and inclusive in who's being represented and not so predictable in where you're including these diverse patients. And then part of this is just because we need to be up to date, So again, I mentored a celiac lecture. I had inherited this celiac lecture. I even recognized some of the pictures from when I had been sitting in the classroom from 20 years ago. And the way celiac was taught when I was a student in 2002 was that this was a disease mostly of white people. That if you're European descent, then you should, think about celiac, and it's really not very prevalent in other races. What we know now, if you look, is that celiac is all over the world. Actually, it is a truly international disease, and in the U.S., actually, the group with the highest prevalence are those individuals with Punjabi heritage. And I only learned that because I started doing the research. I started looking it up and questioning: is this right? This slide that says this is primarily European, and no, it was wrong. It was a dated slide. And so just again, you're not only to be inclusive, but to be accurate and making sure that we're giving correct information. And then recognizing also how our assumptions sometimes can, again, fill in the blank. So esophageal cancer. I was taught, and again, I have to still sometimes challenge my colleagues in how this is taught. You know, again, I'm an IBD specialist, so I don't give the esophageal lecture, but I still remember it being presented that esophageal cancer, you know, you can get different types of esophageal cancer. There's one that is an adenomatous origin that starts with reflux that develops into Barrett's. And then ultimately you have metaplasia, intestinal metaplasia, and ultimately you have adenocarcinoma. So there's this progression. This is more often seen in white patients. And then there's squamous cell cancer of the esophagus, which is more often seen in Black patients. And risk factors associated with that is not reflux and Barrett's, but is smoking and alcohol. So that's interesting. And so again, when I was reviewing the lectures, I was like, well, what is the difference between smoking and alcohol in white patients versus Black patients? Turns out pretty much no difference in smoking between white and Black patients. And actually there's more alcohol use and abuse in white patients compared to Black patients. So just saying smoking and alcohol can lead to squamous cell cancer clearly is not explaining what is going on. And if anything, I felt like is perpetuating this idea that Black patients are smoking and drinking their way to getting squamous cell cancer, whereas white patients just have reflux, and so then they get variants. So again, just thinking through about the accuracy and recognizing what are the messages that we're reinforcing with our sometimes inaccurate information. And sometimes there aren't data out there. You know, you can do the research, and unfortunately, because we're so behind on appropriately studying different disease processes across different disease and diverse patient communities, sometimes we don't know yet, or it hasn't even been studied in certain groups. And so I think, again, being transparent and honest and saying, we don't know about yet how this affects different patient communities potentially differently because these studies are still lacking. So just being, you know, clear about that. And then also, oh my gosh, I'm almost like embarrassed that I have to say this, but just recognizing that as educators, we should be role modeling professionalism, respect for patients, and being humanistic in our cases, and even in the heuristics that we use to teach medicine. So I still remember from when I was in med school, it was reinforced again in residency, again in fellowship. And I even heard people still talking about it when I was a faculty member. And maybe this is, you know, here too, but this line, female fat and 40. Everybody knows what that means, at least in, you know, in my medical school class and in my, you know, among trainees, we already exactly what that means. Female fat and 40. Cholelithiasis. They have gallstones. They need a gallbladder surgery. That was the connection that we were literally trained to create as students. And again, I feel like it's really disrespectful the way that it's being presented. And in one of the clinical or small group cases where this was going to be a case on cholelithiasis, the patient's name was presented as Martha Marshmallow. I think in an attempt to be cute or funny, but I also was like, I don't think we need to body shame our patients to teach medicine. So maybe, and of course, well, I'll leave my own biases out of my next line about who decided on that name. But I also think not only should we be talking about the disparities in outcomes and manifestation of disease, but also in how we are delivering health care. What services do we provide disparately across different communities? And again, recognizing how that also leads to different outcomes. Let's see. So I think also as we're talking about disparities and we're using the literature, the scientific literature, ideally to support the content that we're teaching, we also have to recognize that there's a lot of limitations in that content, particularly when it comes around disparities. I actually now serve on the editorial board for a journal called Gastroenterology. And one of the things that I do is I review and help decide whether or not we should be publishing a study. Oftentimes these are around disparities. And a lot of the time, unfortunately, still now, the way these studies are presenting their data is oftentimes reinforcing the notion, the idea of race-based medicine, reinforcing the notion that race is a biological construct. And it's unfortunate because we need more disparities data. We need more studies that tackle that, but they're leaving out, again, the underlying social mechanisms and real drivers of those disparities. And so they're presenting it oftentimes problematically. So while we should be including these literature in our discussion, let's also make sure that we're calling them out and recognizing those limitations in these studies. And simply we could say, because race is a social construct, because this is socially defined, the differences that we see here really are socially driven. Maybe this study failed to look at that. But we know that that is what's really the underlying etiology here. All right, and now inclusion, wrapping up talking about how inclusive a learning environment are we creating for our learners. And so just recognizing again, who's being called on. And that was also, again, feedback that we got from students. And there was a time where we noticed that many of our students who are women were telling us the boys are always being called on more often. Sometimes I get passed over, on rounds, and somebody's always looking to the male on the team to answer the question. So that was a particular bias that we've worked on in trying to make sure that we are calling on all of the students and the learners on the team, and honestly, anyone who maybe is less likely to speak up, maybe is more quiet, it's not because they don't know the answer. And so just making sure that we're giving them and inviting them to participate. They probably have a great learning point for everyone in the room if we just give them the opportunity to share that. And sometimes that means you have to rethink your teaching style and think through, like, how am I going to invite more participation? If I tend to do things this way, but this is the result of that, how can I do things differently where I'm going to get more participation from more of my students? And that students will know that is expected of them, right? I'm not going to be left out of the discussion, or I'm not going to assume that this other person is going to carry the discussion the whole time. That we're all part of this. We all have something to bring to the table and to the conversation. And again, including diverse educators. That's been one thing that I think as we've evolved our curriculum, that we've been very intentional about inviting new lecturers to come and to make sure that we're bringing in diverse lecturers to teach our students. We want our students to be able to see diverse role models as well, who are here. Let's take advantage of that. Let's not leave our wonderful diverse faculty out of the opportunity to teach. And then again, student feedback, I feel like has always been intentionally brought into the curricular sort of enhancement process. But I think that once we decided to launch this new curriculum in 2020, it was even more intentional. I think an even broader group of students were able to share feedback. And now we've continued that because we really just get so much rich and insightful feedback from our students so often. And we value that very much. And not just creating a space where it's not just a venting space, it truly is that feedback gets translated into change in the curriculum. So this is actually maybe probably left over from when I would talk about implicit bias earlier on, just in case if you've never taken the implicit association test, I encourage you to consider and to take it. Again, now that we've talked about the fact that we all have bias, so don't be like horrified when you see that, yes, okay, so I had these biases. Feel empowered that now you're aware of them. Now you're going to know to look for that potentially and to catch it. Remember, it's harder to see it in ourselves, but it can be easier if we actually have that awareness and know that, okay, I have a tendency to do blank or to leave out such and such. So if you have that awareness, then you're going to be that much more capable of mitigating that bias. And I just wanted to also end with a little bit more on the actual process of sort of like how we logistically have been trying to incorporate DEI in the curriculum. I mentioned a little bit about the Educational Content Review Committee process. So here it is, and I think maybe what I left off the slide is the most important part, which is after it goes through the course director review, the education team review, the DEI review, and then back to the lecturer. It then goes to our students, right? That ultimately this is now presented to our students. All of this, we're talking about mostly about slides and case presentations, which has primarily been the pre-clerkship content. So again, we're still, as I mentioned before, it is an evolution, it's an ongoing process. And we still have to think through how we can have the similar level of rigor in making sure that we're doing everything we possibly can to mitigate bias beyond the classroom, right? In the clinical setting, so that all that hard work that we've done in the pre-clerkship phase doesn't just get undone once they move on into the clinical setting. So I believe that might be my last, so this is my summary slide. So again, thinking about for diversity, we're talking about who is represented. For equity, we're reinforcing race as a social construct and being intentional about including social determinants of health as the propagators of health inequities that we should be including and discussing in the classroom and on rounds, et cetera, in the clinical setting. And then being inclusive about who gets to participate in the learning process, both in terms of students and faculty. So it's a lot of work. There are, hundreds, if not thousands of lectures. Each one of them has anywhere from 30 to 60 slides, so definitely tens of thousands of slides that have been reviewed. And it takes a big team of faculty to review all of those slides and then provide that feedback. It's a lot of time and it's a lot of effort if you really want to do a thorough job, but it's definitely worth it. We feel really proud of at least the improvement that we've made, knowing that it will never be perfect, right? Knowing that we're all potentially going to miss something at some point. And we always have that, caveat with our students is like, we are working on this. Know that we are imperfect, that we make mistakes. We're doing our very, very best. And because we know it's never going to be perfect, we want you to let us know when you pick up on something that we've missed, but know that we're always going to be continuously working on making it better all the time. But it is really worth it. And when you see the end product compared to what was first submitted, a lot of the time it's like, wow, this is a huge improvement, not only because it is more inclusive, less likely to be offensive potentially. It's also more accurate and it's more updated and more appropriately represents the values that we say are our core values at the School of Medicine, at the UMB campus. Our curriculum should represent those values as well. So I'll end with that. I'm definitely happy to take any questions. Thank you for your attention.
So my question for you comes back to the pictures, because like when I go in textbooks, so I do cardiology, I'm not vital, I teach that vital stuff. And so do you have a good source of where to go for medical pictures other than like Googling, trying to find things for more diverse images?
Thank you for that question, because that is part of the problem, right? Is even the resources that we have to try to find images that are diverse are limited. So we have found a few free, because there are plenty that you can also pay. Well, I shouldn't say plenty, but there are some that you can pay for. But there also are some specific resources that we've found that have been very helpful. And if you send me an email, I'd be happy to share that for sure. And even those, again, are not all encompassing, but I think they have been very, very useful in making sure that we're able to show. And I think that because this topic has become so much more part of the forefront, and people's awareness about this as an issue is growing, that hopefully we're going to see more and more resources appear available for us. Yes.
So I'm interested in so it's great that you guys have that at Maryland, but how is like the national kind of situation happening? Like, are there national conferences that you get together and kind of explore implementing this in other areas of the nation?
Yeah, that's a great question too. So the main national organization that really I think has engaged in this discussion the most is the AAMC, or Association of American Medical Colleges. They have two different committees, I guess. There's the group on diversity and inclusion, and then there's also the Committee on Student Diversity Affairs. When we talk about medical education and the classroom, it really is that Committee on Student Diversity Affairs that has, I would say, taken the lead on this topic. And I can share, having been a member on that committee for 3 years. Now, a few years ago, I rotated off, but it's definitely, I think, at least at that time, as of a couple of years ago, still very new. And many institutions across the country have recognized the problem, but haven't quite figured out how they're going to address it. There are other institutions that have developed review committees similar to what we have. And in fact, we've talked about collaboratively writing an article, publishing this particular strategy, knowing that there's probably many ways to do this work, but even comparing and contrasting what is similar in how we've tackled and what are some things that we've been doing differently. But it is, I think, again, something that's growing. So the conversation, I think, has generated more awareness and more realization that this needs to happen. Part of the challenge too, I think, it was sort of interesting. A lot of the people on that particular committee oftentimes are not the people that are giving the lectures. Their staff, wonderful and knowledgeable staff who are there to support students, but who aren't faculty oftentimes, or aren't providers that would be able to bring that perspective right into addressing that at their own institutions, which again is why you need a diverse team of people who are going to work together on this sort of thing. So it is still, I think, a relatively small group of academic institutions that are doing this kind of work. But my hope is that it's an ever-growing trend that we'll see more and more commonly across the country.
Hi, so from the perspective of a faculty member who's on a committee that's reviewing lectures and giving feedback, suggestions for decreasing bias, making sure that disparities are being addressed, et cetera, what are some successful ways that you've been able to kind of get more buy-in from your colleagues or from lecturers who might otherwise feel like this is too much work, or this is a lot to have to revamp their slides, and feel like they might not have time or might not prioritize that?
Yeah, thank you for that question. Because I realized that the way I presented it made it seem like, oh, it's perfect every time. And actually the good news is most of the time it does go really, really well. One of the things that we decided we wanted to do is to make sure that the feedback loop, so when the lecturer gets their sort of fully reviewed slides with all of the feedback from the different phases of review, that it would come back to them from the medical education leadership team. And with the comment to say, any questions, concerns, comments that you have about this, please bring back to the education team. Rather than like singling out or going back to, say, the DEI reviewer that said you need to do this, so that there's not this like back and forth, and to some way to shield the DEI reviewers from that. And again, fortunately, there hasn't been frequent need for that kind of level of shielding and protection, but there has sometimes been occasions where there's been some pushback where somebody might say, well, that doesn't make sense to me. I don't agree why I need to do that. And so sometimes there is some back and forth. What I always find has been more helpful, and I think is well received, is if you do more than just say, that's, this isn't right, or you need to show a more diverse, patient, or you need to include this disparity on such. So I try to go the next step and include, so sometimes I'll just copy and paste in. I'll basically do part of the slide editing and be like, here's a great picture you can use. Boom. I basically have, and it didn't take me that long to do it. And I think maybe it would take that person the same amount of time, but feel more insurmountable, or it might take them longer because they're not sure what resources they should be looking to find those images. So if it's relatively easy and accessible to me to do it, then I go ahead and I put it in there. And so I say, I would encourage you to include this image in your slide because of X, Y, and Z. I also oftentimes will include literature, so link to a study, particularly if it is about, would be really, this is a great opportunity. That's the other thing I say. I don't say like, you left out blah, blah, blah. And I'd be like, this is the perfect time to discuss disparities in breast cancer outcomes. Here's a great article that, you could include in your lecture, and I give that link. So I think when you kind of don't present it as you're a bad person, you did this wrong, right? Nobody wants to hear that. And it's not true. Our faculty are wonderful, right? And these are not intentional exclusions. So coming from a place of, hey, I've got a great idea. This is a great time to include this. And here's a resource that you can use. So now I've even vetted the source, right, that they're going to include. Then I think that's oftentimes well received. It makes it feel more feasible now that they're like, oh, okay, great. So I'll include a bullet point here, and I already have the reference here, and I'm going to include that. And it's really wonderful. Sometimes you also do get the feedback, like I'll get an email from a lecturer who just says, hey, I really appreciated you pointing that out. I would have missed that. And I'm really, really glad that you noticed that. And it's a better lecture now. So a lot of the time we also get a lot of positive feedback from the review process. But I think going that extra mile, doing it in a very non-confrontational way and just saying, hey, this is a way to make this lecture even better, and providing a resource is the best way to get a good outcome.
If I can just comment as someone who does a lot of teaching at the School of Medicine and Cardiology, like this process is awesome. Like, because, some people can be perceived as like, oh, you're getting feedback, but like with the vitals, like I teach the hydroxyl and nitrate heart failure stuff. So I had such a good conversation. So like, making sure that I presented it the right way to faculty. And then I know this year we have like template slides that we're using, and some of our course managers will do that there. And I'm like, this is just so awesome for the students, like making sure we do our terminology and stuff. So we always say like, oh my gosh, the amount of work that you guys must do. But like you said, like there's so much we may not know. And then getting somebody in DEI who can really give us that insight and like putting things in there that we haven't even thought of is just awesome. So kudos to you guys, because it's incredible what you do. And like if other schools and programs could do that, that would be amazing as well.
Well, thank you. I mean, actually, you made me think of another point that I've also done is, because it's true, also like, I did that too. So like, again, just sort of saying like, we all do this. But like, I also left this out. And so, somebody gave me this feedback, so I'm going to share this with you because I think it was helpful for me. Right. So again, just kind of leveling the playing field. So like this, we're all helping each other out here, is another way I think to get more buy-in, as you said.
One of the faculty members online had a question for you. It was one, Zach, do you want to speak up?
Hey there. Thank you so much for the presentation. I thought it was fabulous. I did want to ask a question. This is a cardiology pharmacist here, and so you talked about disparities, and one of the disparities that comes to mind is disparities in African American or Black patients with heart failure. And you talked about hydralazine isosorbide, and I venture to say you've had these conversations with Kristen too, about how it was kind of a race-based study, so to speak. People who self-identified as Black were enrolled in that heart failure study that got Bidil its indication. The study showed a very clear benefit, though, in patients who self-identified as Black, just not just in heart failure hospitalizations, but survival too. And so while I certainly concede that, this kind of race-based medicine approach is not what we should be doing, how do we approach that with our students when we try to explain, hey, this drug has a benefit, here's how it was studied? And then I guess, how do you go about having that conversation? And maybe I just need to have a hallway conversation with Kristen, because I think you've probably vetted it with her, but I think it would be good for everyone to hear.
No, I thank you for that question, because it's similarly along the lines of sometimes when I have another talk I give just about anti-racism in medicine in general, and sometimes the question that I get or comment is like, well, maybe we shouldn't even be doing disparities studies. And if you're saying that there's no, that we can't really define races biologically, why are we even doing these studies? And I'm like, no, that is not what I'm saying. I'm not saying that we should not be studying disparities across race. I'm saying that we need to be rigorous in how we are explaining the disparities that we find. In this case, I would say we should be rigorous about the mechanism of action of IMDR and why it is, and Bidil rather, and why it is beneficial for some patients and its association with nitric oxide. So that's really the real benefit there, I would say, and just recognizing that if we say African American or Black patients, recognizing again, because it is a social identity, that many patients who will identify, who would participate in a study and check the box and saying that they are Black or saying they're African American, might actually have a very diverse genetic makeup and ancestral background. I find that problematic too. For example, I could use myself as an example. I mean, I am Latina, and so I could participate in your drug study, and I'll check the box as Hispanic or Latina or Latinx, whichever option you give me. I'll check any one of those. But I have told you nothing about my genetic background and my ancestry, which, being Latina, means it is some combination of African, Indigenous, and European ancestry in different proportions, depending on where in Latin America my family is from. And so I think what the problem becomes is when studies try to use race as a proxy for biology or for genetics too superficially and aren't rigorous in terms of that classification, aren't recognizing sometimes even how patients were categorized into races. Was it self-identification? Did the provider just decide by looking at the patient that they knew what the patient's background was? And also, if, again, we're not saying that there aren't connections between genetics and disease, genetics and how we process drugs, because there are. The problem becomes when we try to use race as that proxy for genetics. And so I would say that you can certainly teach that, yes, there is this potential benefit from this drug because of this mechanism of action in patients who have this genetic predisposition. It's possible in patients with this ancestry, we may see more of that particular genetic occurrence in this ancestry, but recognizing that not all patients that check this box and identify within this category have the same ancestry.
I think that's all the time we have for those guys. So I'm going to stop there on this one. Thank you so much, Dr. Quezada. We appreciate your time. So it's good.
Absolutely. Thank you all.